Economics and safety of continuous and interrupted suture hepaticojejunostomy, an audit of 556 surgeries. Hepaticojejunostomy is one of the common procedure done, and it is a standard method of bilioenteric reconstruction. There are two techniques of anastomosis. One is continuous suture hepaticojejunostomy and other is the interrupted suture hepaticojejunostomy. In continuous suture hepaticojejunostomy, in 9.9 out of 10 times, it is done with two sutures taking continuous bites. Whereas in interrupted suture technique, we take multiple sutures to make the anastomosis. Most of the abdominal surgeons generally prefer to go for interrupted suture technique because there is a presumption that it is there is a high risk of anastomotic stricture, though the technique is quicker. Continuous suture technique is comparable to interrupted suture technique in liver transplantation in multiple series in literature in terms of biliary complications. However, economics and safety of continuous suture technique and interrupted suture technique in terms of complications, both early and late, and related patient-related costs were not reported previously. This study compares the safety and economic implications, both material cost and time, associated with the two methods of anastomosis, as well as the post-operative course and long-term outcomes in non-transplant patients. This was a retrospective observational cohort study done in our department. All consecutive patients undergoing bilioenteric anastomosis in the form of hepaticojejunostomy, either done for any benign or malignant condition, between January 2014 and December 2018 were included. We have included patients with bile duct diameter more than 8 millimeter undergoing hepaticojejunostomy, irrespective of the pathology, because in ductal diameter less than 8 millimeter, it is difficult. Technically, it is difficult to do a continuous suture hepaticojejunostomy. In smaller diameter ducts, it's better to go for a interrupted suture technique. Patients with type 4 or 5 biliary stricture, which is stricture above the common hepatic duct, where many a times we have to go for two or more anastomosis. Those are excluded. In case of multiple bilioenteric anastomosis, they are also excluded. And if there is a concomitant vascular injury, either in the form of hepatic artery or portal venous injury during dissection, then all these patients are excluded because there is a high chance of stricture rate. So they are excluded from our study. And also hepaticojejunostomy performed during liver transplantation. Though we have a patients of liver transplantation in which continuous suture hepaticojejunostomy were done and patient is doing well. In all patients, preoperative demographic profile, intraoperative parameters were recorded, and anastomotic time is defined as time from first suture bite to the last knot in hepaticojejunostomy. For cost comparison among the techniques, mostly hepaticojejunostomy is done by two sutures. One is polyglactin, which is uh, a braided suture. Its cost is taken as 486 suture per suture length, and polydioxanone PDS, its cost is taken as 686 per suture length. Operating room charges are billed at the rate of 5,000 per hour. Post-operative morbidities are recorded according to the Clavin-Dindo grade, which is based on the management of all the post-operative complications. And hepaticojejunostomy leak was diagnosed if there is a bilious drain output or there is an intraabdominal collection which is being aspirated or placed a PCT which showed a bilious aspirate. And in case of bile leak and collection, interventions are done in the form of USG or CT guided single time aspirations or percutaneous drainage. If there is a hemodynamic instability or uncontrolled sepsis, the patient is planned for a abdominal re-exploration. As our routine follow-up protocol, most these patients are being followed at the interval of 3 months. If they are doing well, then 6 monthly, then later on yearly, with serial ultrasonography of the abdomen and liver function test to look for any signs of stricture. If there is increase in serum bilirubin or alkaline phosphatase, or the patient is having symptoms of cholangitis, then these patients are subjected to examination with MRCP. And for long-term outcome of hepaticojejunostomy, they are reported with using the McDonald's criteria in surviving 540 patients. Grade A and B outcomes are regarded as the good outcome. For statistical analysis, all continuous variables were expressed in the form of mean and standard deviation. In case of skewed variables, median and interquartile range was used, and all the statistical tests were done using SPSS version 22 software, and independent t-test and Fisher exact test or a chi-square test were used. P-value of less than 0.05 was considered statistically significant. Among the 556 patients, 86 patients who underwent hepaticojejunostomy, 556 patients could qualify the inclusion criteria. During the study period of 5 years, 10 consultant surgeons and 20 trainee residents participated in this study. All the continuous suture hepaticojejunostomy and 46 interpreted suture hepaticojejunostomy are carried out by a single consultant who is also a liver transplant surgeon, and other interpreted suture hepaticojejunostomies were performed by surgical gastroenterology consultants and as well as trainee residents under supervision. In the demographic and clinical characteristics, in both the groups, uh, age, body mass index, gender, all are comparable. In the etiology of the patients, in benign etiology, colorectal cyst, benign biliary stricture, colorectal lithiasis, and Meiji syndrome, all these are comparable among both the groups. In malignant pathology, most common pathology is periampullary carcinoma, followed by carcinoma head of the pancreas, gallbladder cancer, or distal cholangiocarcinoma. All these uh, etiologies are comparable between both the suturing techniques. Coming to the intraoperative parameters, uh, among the type of suture used in continuous suture hepaticojejunostomy, most common type of suture used was monofilament PDS suture. However, in interpretive suture technique, most common suture used was vehicle. The mean number of sutures used was uh, approximately 2 sutures in continuous suture technique and approximately 13 sutures in case of interpretive suture technique. Uh, there was no difference in ductal diameter or stoma size in both the groups, and there was a significant difference in terms of duration of anastomosis, which is approximately double in case of interpretive suture hepatitis technique, and the cost of suturing technique is also significantly more in case of interpretive suture technique. It is around uh, 6,000 more as compared to continuous suture technique. There was no difference in duration of drains in days in post-operative period or in the hospital stay. We have observed 38% morbidity in case of continuous suture technique and 42% morbidity in case of interpretive suture technique, which was not statistically significant. There was more bile leak in case of interpretive suture technique as compared to continuous suture technique, which was bordering on the significance. In terms of Clabin-Dindo grade, there was no statistical significant difference. Clabin-Dindo grade 5, which is the mortality, there are 3 mortalities in case of continuous technique and 13 mortalities in case of interpretive technique. All are because of septic shock and multi-organ failure. In the re-exploration, which is grade 3B, most of the re-exploration are done for intraoperative bleeding in case of patients undergoing pancreatic, and there are three patients. Re-exploration was done for bile leak, for intra lavage and drainage. One patient in case of continuous technique, and two patients in case of intra technique. In follow-up, the median follow-up was 2 years in case of intra technique and 3 years in case of continuous technique, which was not statistically uh, significant. In terms of long-term complications, according to McDonald grade, which is based on the clinical parameters and biochemical parameters, uh, there was no statistical significant difference in grade A, C, and D. However, there is more grade B outcome in case of interpretive technique. And in case of re-intervention, which is grade D, there was no statistical significant difference. In reviewing the literature, there are only few series which have looked into this technique of anastomosis. Most of the studies initially they are done for liver transplant, because in liver transplantation there is issue of cold ischemia and warm ischemia, mostly warm ischemia time. So, and they have what they have found that in case of first study done in 2006, there was a statistically significant, non-statistically significant difference of bile leak in case of intra-operative suture hepaticojejunostomy. However, there was no difference in stricture rate. In case of in the second study done in 2006 also, there are more stricture rate in case of intra-operative suture technique. Further studies also shown that uh, stricture rate were uh, are comparable between the techniques. Previously, a study done by us in 2016 in 40 patients in each group, there was significant difference in terms of duration and number of sutures. Uh, However, the bile leak didn't reach the significance. The latest study, which was done in 2020 by Hamid M. et al., they have also reported that duration and number of sutures are significantly less in case of continuous suture technique compared to interrupted suture technique. So in our study, we have found that long-term results, morbidity, mortality associated with continuous suture technique and interpretive suture technique are similar. Continuous suture technique is more economical, it is quicker and also simple, and is associated with a lower bile leak rate than interpretive suture technique. So continuous suture technique made is a routine use in suitable ducts, making which makes the biliary reconstruction more affordable and saves OT time, and also it permits increased utilization of the operating room.
The analysis of what work we have done, and it shows that the cost is significantly different. The anastomotic time is much lower, the bile leak rates are lower, and the stricture rate is not different between the two techniques. What is important is to appreciate the study in light of the load of the work that we have. We do, on an average, more than 100 hepaticojejunostomies per year. After cholecystectomy, this is the commonest surgical exercise which is done by the Department of Surgical Gastrosurgery. Till date, we have done more than 3,000 hepaticojejunostomies in the department since its inception in 1988, saving more than 6,000 rupees per hepaticojejunostomy in today's cost. In terms of future costs alone, can translate into avoiding unnecessary expenditure of at least rupees 6 lakhs in terms of future costs alone, and rupees 25 2.5 25 lakhs in terms of operating time costs per year. If you make a projection based on the 3,000 cases we've done over 32 years, it translates into saving rupees 1.8 crores in terms of future costs alone. This work has been accepted for publication in Annals of Hepatobiliary Pancreatic Surgery. Over to you, Dr. Eash, for discussion.